probably wouldn't hit too hard.
Well, welcome. We have so many times talked about how important the Regional Medical Center is to the Milford community and to our families, and how hard it is for the management at the Regional Center to maintain independence. I mean, every day we read about another community hospital that couldn't, and yet we've had the little engine that could, the Milford Medical Regional Center. Tonight we're going to talk about a huge issue, and we've got a couple people on, the better Kelly and the normal Kelly.
Right.
But why don't we start with introductions?
Sure, Al. So I've been here before. Ed Kelly. I'm the president and CEO of Milford Regional Medical Center, and I've been at Milford Regional for 25 years.
And I'm Judy Kelly, Vice President for Patient Care Services and Chief Nursing Officer, and I've been at Milford for 10 years.
You know, and it's amazing because I remember I was born in the Little Red Hospital. You know, back then it was the little red building that we never knew. You know, you never knew how long it would last, and Whitensville was a separate hospital, and all of a sudden it's amazing between you and Frank what you've grown the medical center in. But let's start with a basic question. Before we get into opinions, or how's the medical center doing?
You know, we're having an off year, Al. You know, we're busy in a number of areas. It's a tough business just in general for all providers in Massachusetts. We actually had some turnover in certain specialties, particularly in surgery. But I'm happy to report that we have a pretty big turnaround plan, a number of surgeons that are coming on staff next year. Hopefully we'll be back to tell you about that. But we're definitely off, and again, excited about our plans, but very worried about why we're here tonight in terms of the...
But even without question one, I mean, you've been able to hold the loss down in a horrible year to a few $1 million.
Yes, yep.
And, you know, when you think about it, you know, this whole question one, people say it's about the money. But the money is what keeps us able to have oncology services, surgery in Milford.
Right.
I mean, you can't just ignore something that's going to cost us more millions of dollars.
Right. So in terms of Milford Regional, the way I've summarized really our success, we've recruited a lot of physicians to come to Milford that work primarily in Milford, but we've also had a special arrangement with academic medical centers. And as I've mentioned before, for a community hospital to have a relationship with one academic medical center is
well, that's
a big
a feather in anybody's cap.
We have four. We have four. So we have long-standing relationship with UMass Memorial. A lot of that centers around teaching programs and lots of residents and medical students at Milford. And then about 10 years ago, a newer relationship that centers around our cancer center with Dana-Farber. And that's been great. And again, we have expansion there with Brigham and Women's, adding a second linear accelerator, so the ability to do more and in more advanced type of radiation therapy. And then Boston Children's Hospital, we've had a relationship with them now for about 3 years, where we have a pediatrician from them 24/7, and then a second one for about 12 hours a day. So again, we want to provide local services. Sometimes physicians can come from Boston and Worcester and do services at Milford, and then other times if they need a higher level of care, if they need that academic medical center, we have quicker ways to get them to Boston or to Worcester.
And you'll never blow your own horn, but when I think of a linear accelerator, the state doesn't just let anybody who can afford it put one in.
Right.
They have to decide where they believe the limited number of accelerators, and was it $5 to $10 million investment?
Right. That's correct. Yeah.
Will go. And yet here we are in Milford, and we're getting our second one.
Right. Right.
So that's going to be a heck of a vote of confidence in the regional center.
It is. It's in its, you know, patients that need radiation therapy need daily services, and so if you think about driving every day for a month or so, that would be really wearing. And it wasn't that long ago, 10 years ago, that's what patients had to do, but now they can get it right here in Milford.
Well, you think about the psychological burden. Compliance is directly related to how the patient feels. I mean, I know a dozen years ago when my mom was diagnosed with intestinal cancer, the idea of driving her every day into Boston, fighting that hour-plus traffic each way, this is one of the times where you say, I walk to school uphill both ways. Well, that's not a joke when you have to drive into Binney Street or wherever to the Farber. The tension would not be healthy. Driving down the street to her little Milford hospital, in her mind, it's still the little red building. I know it hasn't been that way for many decades. But the tension that, and I always joke, the environment you've set up, Ed, as she calls it, Dr. Mona is still there.
Right, she
And
still
she
is.
goes there it's not Dr. Katis, the oncologist, it's my Dr. Mona. I go visit her.
Right.
And it just takes the burden off of a 94-year-old woman that she can just drive down the street. But at the end of the day, you've got to come up with a way of funding it and maintaining, years ago we lost $9 million. Then everybody said, oh my God, how terrible. Well, no, there's communities who lost their entire medical center.
Right.
And now we're coming off a few $1 million loss again as Medicaid strangles the reimbursement. And now we hit question 1. And I've heard so many things about question 1 that I'm so happy you've come on the show to talk to us about what is the real fact versus fiction. Sure. Now, I hear it's all about the money. And then I start reading and I find out maybe it's not all. It seems like it started about the money. I can't fault the union. I mean, their job is to do better by their nurses. If they put this through and it dramatically increases the pay for nurses, can you fault the union? I can't. They're doing their job. But walk us through, because it's easy to say it's all about big bad Ed who's trying to squeeze money. Sure. But it doesn't seem like it's just about squeezing extra profit, because last time I looked, I didn't know that you had a lot of shareholders that get profit.
Right. Al, what I thought I might do is have a few opening words about the ballot, but first, you did touch on it a little bit. I often introduce Judy Kelly. By the way, there is no relation.
There's not a family Kelly here.
No, but Judy often is the important Kelly in the room, and the reason I say that is that she's clinical. She's really the leader of nursing. I'm more administrative, and for me, it's all about developing a strong team, and I couldn't be more proud, or Milford couldn't be in a better position than having Judy as our VP and Chief Nursing Officer.
That's why Joke said she's the good Kelly. She's the one that brings the smile and the patient care. Yeah. But without Ed, you wouldn't have the opportunity to do it.
And Judy, just tell me just a little bit about yourself and how long you've been at Milford.
So I've been at Milford for 10 years, and actually, from the time I came, the nurses at Milford are exceptional. And I've worked in several different areas at the hospital. When I first came, I was in the outpatient area, endoscopy, outpatient, and then I spent several years in the perioperative in the OR, and then as director of inpatient. So I feel like I've gotten to know nurses across the whole hospital, and really they're a great team. They provide exceptional patient care, and I think you'll see as we talk about the ballot. At face value, who wouldn't want more nurses? I would agree with you. But it's the detail of the approach of this ballot that really worries us.
Yeah.
And there is something special, because my mother had to go now twice this month or last month to the Taj Mahal Hopkins, to this beautiful medical center. And it wasn't just the facilities. Mike Newstein, head of infectious diseases, looked over my mom. That's pretty impressive. The CEO visited my mom. You know, it's that little extra personal care that makes it seem like our medical center.
Yeah. And when I visited the patient, in this case your mother, I also visited the staff and got to talk to the nurses and engage. I know you often say you have 10 viewers. I think you're going to have 11 or 12 or maybe more, maybe more. There is a nurse that took care of your mother, Jackie. So she's in Milford, hasn't seen the show, but she's going to be, her father's going to be recording it for her.
All of them, Ed, they had somebody when I wasn't there who would sit with my mom and speak to her in Portuguese.
Yeah.
Now, did you need to do that? Oh no, I mean my mom speaks English, but did it calm her down?
Yeah.
But you know, now we talk about 10, my 6 versus, you know, the estimated 10 people that watch. First thing I hear is 86% of all nurses are in favor.
Let me just give a little overview, and Judy's going to talk specifically about that. So this ballot question 1, how it got to be where it is right now, it was introduced by the Mass Nurses Association, so the union of nurses. Now, they represent 25% of registered nurses in Massachusetts. So they, a fraction, it's a pretty big number, but it's certainly not all nurses.
It's a fourth of the nurses.
Yeah, and I think in the ballot is specifically related to government mandated nurse staffing. So that's what this is about, having the government dictate a very rigid standard in terms of ratios for nurses and patients. And I think, as Judy said, you'd say, well, why not? And I think you can talk, you know, I've talked to a lot of nurses at Milford that are on both sides. Many sort of initially say, geez, I want to take better care of my patients. Why wouldn't I want more care? And they're supportive. And others who I've spoken to and who would say, geez, it's very rigid in terms of when I can go to lunch or break or anything like that, or how we deal with critical patients, our flexibility to deal with critical patients. It's very rigid. It takes away the ability for nurses to critical think, which is a big part of nursing.
Wait a minute, I like the Milford nursing staff making decisions to take care of Milford people. It seems to have worked out well.
Yeah, and even if things are going terrific at Milford, this ballot initiative, if passed and implemented, would turn the whole state upside down. So even if we were all set at Milford, it's going to create a demand for nurses that we just can't meet.
What problem, sorry to interrupt, but what problem are we trying to fix? Because every time they tell me I'm from the government, I'm here to help you, I get a little nervous. You know, and it's bad enough when they're dealing with my pocketbook.
It's true. But so we'll get to what the problem is, but what it's going to mean is a real demand for nurses. So there's going to be pressure by the big hospitals to pull nurses in, and what you're going to see is that nurses that are in outside of the hospital with home health, with behavioral health, with skilled nursing facilities, they're going to be pulled into hospitals because there's going to be this demand.
You're going to increase the pay, you're going to fight for them, but
demand.
Now who takes care of the nursing homes?
And we're likely to take care, we're likely to lose nurses to bigger places.
So you'll lose them to the big teaching hospitals.
Yep. So
then you'll pull, but the last I looked, you couldn't hire enough nurses before this initiative.
Right. And then because this is across the board, behavioral health. So the area that we've been trying to fix is going to lose an estimated 1,000 beds in the state because of this standard.
Okay, help me understand. First of all, I understand we don't have enough nurses. So this is going to mandate you adding more nurses everywhere.
Yeah.
Is it achievable?
Well, no. And I think one of the issue is all the time. So the standards here are that the staffing ratios are all the time. And I'll let Judy explain that first and second shift, we have the same standard, but overnight, we don't have that same standard, as most hospitals in Massachusetts don't. So what that's going to mean is, in the short run, we're going to have to meet that staffing. So how do you meet that staffing? We're going to have to we're going to have to shift people from the first and second shift to the third shift, and likely we're going to have to close beds.
Yeah, right.
Now, when you say close beds, my understanding, you can correct me if I'm wrong, is that it's going to be X patients per nurse.
Right.
So if you only have Y nurses,
right.
and my mom comes to the ER, you're going to turn around and say the inn is full, right?
Right. Or she would have to be held and stay in the emergency room, which we know is
But
already an issue.
when that gets
yeah.
full,
Right.
what happens to my mother?
Well, that's a good question. I think as a practical issue, patients that are in the emergency department aren't going to be able to go upstairs because of staffing ratios. Patients that are in the hospital that can leave the hospital potentially aren't going to be able to go home because of either home health staffing or skilled
But wait a
nursing
minute.
staffing.
Big hospitals pull from Milford. So Uncle Ed pulls from nursing centers. Now you turn around and say, okay, we've treated these patients, we can send them back. But aren't they going to be under the same mandate?
Yes. Well, the issue, they're going to have a different mandate. They're just not going to have any staff is what.
Well, what
it
I'm
would feel,
saying, I
right.
mean, all of a sudden, you've got the nursing home saying, Ed, great, but you took our staff.
Right,
We can't accept any patients,
Right.
right?
Right.
Right, right.
So again, I hate to be cold, but what happens to my mother?
right.
Right.
Yeah. So, and then I think your big question, which again is the 86%. I'm going to let
Right.
Judy explain
Well, let's
that.
start with 86% of every nurse in Massachusetts
Right.
is for this. At least that's what the commercial
So
says.
the 86%, and again, that's what we've seen in a lot of the advertisement for, 86% of nurses vote yes. So the 86% was a survey done by the MNA on 302 nurses. There are 130,000 nurses in the state of Massachusetts that are like active and have their license. So it's a very small number. It's 86% of that 302
But
nurses.
the union represents 25%.
Right.
So now I'm a chemist, not a math major, but it sounds like
It's
even if they did a representative sample, it would be more than 300.
Yes.
And they're saying 86% of our 26%
Right.
are for this.
Right, right. It was a random survey, and if questioned on it, they have said, yes, it was a survey of 302 nurses, but the way it's presented, even in the information that was sent to people's homes, is that it's 86% of
Of
nurses.
all nurses.
Which is not accurate.
Okay, Judy, I'm going to be mean and put you on the spot.
Yeah.
Is this going to help people like my mother or hurt them?
I think it will hurt them. I think it will decrease access to care, which is what you're talking about. Your mother is a patient, she needs care, and there are nurses in the emergency room. And nurses are they're team-oriented, they work together, they help each other. We never know how many patients are going to come into the emergency room on any given day. And so you try to prepare the best you can. We have excellent staff, but if they reach their maximum ratio, then they're put in a difficult position. They can either, break the law, by, breaking that ratio if it's mandated, and the hospital would be fined in order for them to do that.
I was going to ask, now, this is Milford.
Right.
We never needed Beacon Hill or Capitol Hill to tell us how to take care of our kids or our parents.
Right.
But what happens if Uncle Ed here just says, I don't care. I'm going to take care of these patients. What's the downside?
I think the risk is it's not going to be driven by Uncle Ed. I think it's going to be driven by our nurses. This is
you just said no. I'm going to admit more patients in because I got to take care of them.
So we will have to report, and every time that we don't go by that ratio, there's different ratios for different
No, but what
clinical
happens?
areas.
Do they just say bad Ed and?
No, they fine you. So they fine you $25,000 for every infraction.
Wait a minute.
So
you got 5 patients. We're at our max.
yeah.
And knowing Jeff Hopkins, he's never going to turn his back on anybody. But you're saying if he let 5 patients in, you'd get handed a bill for $125,000 worth of fines?
Yeah, if you.
That's the way it's
yes,
written.
Yeah.
Which you would then have to make up for by cutting services, or, I mean, where are you going to get that kind of money?
It's not funded, so it would be.
And you can't ask Medicaid to pay more because
No.
you took care of it.
Ultimately, it may be passed on to patients if insurance goes up and the higher copays to afford this higher.
Eventually,
Because healthcare costs goes up.
when
Yeah.
healthcare costs
Right.
go up, the people,
Right.
we're
Will
going to
pay
see
it.
our premiums go up.
Right.
Well, through the Mass Hospital Association, they've commissioned an independent group to estimate what the cost of this ballot would be if it passed, and it's 1.3 billion in the first year and 900 million in follow-up years. So it's staggering in terms of cost. So for me, it's not about the money. I mean, the money's important eventually, but in terms of care, this is going to bring our system into gridlock. So patients aren't going to be able to move through our system like it is now.
I can't deal. I'm just a kid from the Heights. When you use numbers like 1.3 billion, okay, but how about Milford? How much is it going to cost our medical center?
So from the same study, 5 million annually.
So you're going to make up $5 million in extra expense.
Well, we'd have to find the nurses first.
Well, if you could.
Yeah.
If you could hire, because, I think of, I joke with Uncle Phil about he can't get enough primary care physicians, to take care of our community. And seems like nurses are right there with the PCPs,
Right.
that you can't find enough.
Right.
But even if you could, you're going to come up with $5 million?
Yep. That's the
And-
estimate.
Are you coming up with that improve medical care?
Well, again, I think we're trying to come up with a simple message, which I'll get to in a minute. But to answer your question, where's the money going to come from? The Mass Nurses Association, the union, would say that it's going to come through more efficiency, shorter lengths of stay, and less readmissions. The math doesn't work up. So one big question is where's the money going to come from? But what's going to hit us before the money part is the rigidness and the gridlock and the inability to move patients. So we're not going to be able to discharge patients. Our emergency department is going to fill up with behavioral health patients. We're not going to be able to move patients upstairs. And in fact, this has the likelihood to be a downward spiral. As you try to transition staff from the first and second shift to cover the third shift, they're not going to be happy. You could run into turnover. So, like, what happens? So, one of the issues here is that a ballot process to deal with something this complex is not the right way to go. Really, this something like this would typically work through a legislative process where you can have all parties participate, and the state is involved. But by bypassing that process and going to the ballot, I think you're really going to run the risk of chaos in terms of patients, and you're going to have a lot of adverse outcomes, potentially closings, for something that in theory sounds on a first blush as a good thing to do.
Well, it's like world peace. How do you say world peace isn't good?
Right.
But you're going to legislate world peace.
Yeah.
Okay? I mean, I'm really having a hard time. You're telling me there's not enough nurses to hire. So that, I mean, from a union point of view, I love the idea. If I'm tasked with doing the best for my nurses, my 25%, this is going to help them raise their value and their price. Okay, but then what happens when downstairs at the ER fills up?
Right.
Are you going to close the doors and say, go to Framingham?
Right. And potentially, you could be in a situation where you have to mandate a nurse to stay because you have to maintain this ratio. And that's not the way you want to work nursing.
But Judy, indentured servitude, there was a guy with a beard and a big hat that said, we're not doing that anymore. You can't force me.
Yeah, exactly. And you don't want to, but this rigid mandate would put you in that awkward position of mandating and of floating nurses. I mean, nurses typically really, you want to be on your own unit. They have different specialties. But if you always had to be aware of the numbers, Again, patients aren't numbers. I mean, patients are people, and they're different, and their illnesses are different. So to go just by numbers, I mean, if I'm an experienced nurse and I'm working next to a brand new nurse who's just out of school, and she might only have 3 patients, but I might say, you know what, I'm going to take a 5th patient because I can handle that, and my patients aren't as acute. So you work together, and I think to take away that in the moment decision making, clinical situations change, is just, for the profession of nursing, is not a good situation.
I think the thing that worries me the most is, I mean, for somebody who's seen how wonderful the nursing staff is, I don't believe for a moment any of them I've met would put a patient at risk.
Right.
I see how much they care. They come in, they take care of my mother, they're asking her, they didn't have to. They're dealing with, but to take that away and say, I'm from the government, so I'm going to tell you, the most you can have, by the way, is 6 here or 7.
Yeah.
Philosophically, intuitively, I don't like somebody that's a sociology major making a decision that restricts a nurse.
Right.
I don't get it. And then, from loading, I hate to be cold about loading studies, that I need more on this shift or less on that shift. Does this allow you to balance then?
Well, this has the same staffing on all the shifts.
So I either staff for the peak times, or I staff even across and then limit what I can do at peak
It's the
times.
latter. It's the latter under this proposal. So we'd have to staff the same around the clock, which means we're going to have the ability for less capacity.
So all of a sudden you're saying, if I had 100 patients, because I could, manage the nursing load, well, now I got to cut it to 90,
Right.
so that I can not pay $25,000 a person.
Right.
Yeah.
Well, but wait a minute. What happens? My mother's one of the 10.
Exactly.
Yeah.
Where does she go?
Exactly. And nurses also. I mean, nurses are, even if you had your perfect staffing on, just like the patients, nurses, if you had a nurse that was ill, or they had to stay home for a sick child, or whatever it is, we try to get another nurse to come in. What if you couldn't get a nurse to come in? Then what do you do in those situations? Normally, nurses work together, and they come up with a plan. They take excellent care of the patients. But to have that added burden of, well, do the numbers match? And, to make it inflexible and always about the numbers is
And
really
I don't
not a
want
good situation.
a nurse that's now done a 12.5 shift.
That's right.
Don't get me wrong. I'm not questioning their integrity, but they're human.
Right.
So if you had to mandate them to stay because, oh my God, we did fill our limit and 2 nurses got sick.
Right.
Well then, instead of 8 hours, do I want a 6? It used to be like the interns or whatever, the residents, where they said, they're going to work 24 hours.
Mm-hmm.
Not
Right.
quite sure human beings are at the same peak performance
Right.
at hour 23 as they were at hour 1.
Right. The other thing we didn't talk about, when this goes into effect, if it's passed,
Well, you got time to blend in and build up, right?
January 1st, less than
Yeah.
60 days.
This year.
Yes.
No, come on, seriously.
That's what it
Seriously,
calls
that's a failed
That's-
attempt at
It's
humor.
almost impossible when you think of the number of nurses you'd have to hire and train. Orientation takes time. I mean, it's really an
So
impossibility.
in 60 days, you got to find them, train them, and bring them in. Or sounds like you're just going to cut the number of people we can deal with.
Capacity. Right. In the short run, yeah.
No, I mean,
And for a while, until
you can find the right.
Right.
But again, if you're, I don't want to be cold, but if you're poaching nurses, I mean, you're getting your nurses poached, you're poaching nurses,
Right.
and now all of a sudden you say, okay, Mrs. Correa,
Right.
I can let you go. Oh, I can't let you go back because the nursing home can't accept you anymore.
Right. And I mean, the only other state that has this is California. So when you look at, there's no other state that has mandated ratios except California.
And how's it working there?
And ours is what's proposed for us is much worse. It's not even apples to apples.
No.
But just to talk
Yeah.
about what happened in
It
California.
was in 2004 that they passed it. And their quality scores, Massachusetts has higher quality scores than California. So, I mean, right there you look at if the purpose is to provide better care, then you would expect the quality scores to be higher. So they're not higher. And they did have hospitals that closed. And we have a nurse that works at Milford. We have a few that have worked in California and experienced that and shared some of the stories.
So, okay, again, I'm a little slow and I'm old. We got a system that's doing better, but we're going to go to the system that for 12 years or whatever has proven to do worse than what we already have.
Right, there's no evidence to show that there's any improvement in quality, and in fact, their scores are less than Massachusetts.
But more than a decade ago, the FDA went to an evidence or a risk-based philosophy.
Yeah, and how long did it take California to implement it from when they passed it?
Yeah, it took them like over 5 years to implement it.
So we're going to implement a system that's worse, that took them 5 years in 60 days?
Less than 60 days.
Yeah.
Okay, again, I know I'm slow, but I'm missing something here.
Yeah.
Why is there a benefit to people in Milford to do this?
Yeah, I mean, I don't think there is a benefit.
Yeah, I think that's why we're here. I mean, usually we're here to celebrate or to tell you about something that's going great, and we want to come back and do that because we do have a lot of exciting things happening at Milford Regional. But we're here. This is really a very serious issue for us. It really threatens healthcare as we know it in Massachusetts. Healthcare in Massachusetts isn't perfect, but this is going to make it worse. And I think to answer your question, why would we do this? I think there's a perception, this 86% that's been thrown out.
It's great marketing.
Why wouldn't you do it? There's no. I mean, you took me off my sort of opening speech, but in terms of the nursing care that's provided at Milford, we wouldn't trade it for anything. In terms of skill and care and compassion,
and dedication
it's the best.
And
it's
everything
the best.
else.
It's the best. And I know with your mother and being at the hospital, and myself as much as I can, and even my own family, I'm very observant of what happens in a hospital in nursing care, and sometimes it's incredible to just see how it works. It's very flexible. As Judy says, it's team oriented, and we don't want to change what's working well. We want to try to improve what could be better, and it can always be better. But this isn't the right way to do it. The right way to do it is not by a ballot to work around a legislative process. This issue's been before the legislature for a number of years, and again, the legislators have implemented pieces of it, but the reason it hasn't been implemented is exactly because of what we're facing right now.
So now, I mean, realistically, you sit there and say, if they tell you you must, you will. All kidding aside, if there's a law passed and it says you have to have, what's the ratio?
Well, on the inpatient units, it's 4-to-1. There are different ratios for different clinical settings.
Let's take 4-to-1.
Yeah.
So if you have 100 nurses, that's 400 patients. Period. End of story. But that 4-to-1, you have to staff for 24 hours a day.
24/7, yeah. So it gets a little
So, you
complicated.
sit there and say, wait a minute, it's really ineffective. It's like when we want to expand our firefighting capability. 3 people buys you 1 per shift.
Right.
So it's 100, if you had 400 nurses, you only have 133 effective nursing slots.
Yeah.
I'm still waiting for it. Why will this help? And I'm not hearing. I mean, I can see it'll increase the pay for the nurses. So God bless the union. It seems like it is about the money. But you're not going to pay your stockholders, because my understanding is you're not for profit.
No, we're not for profit, tax exempt.
So there's not like, Ed, you're protecting rich stockholders that get dividends. Every penny that we suck out of the medical system, especially if it's in fines, all you're going to do is cut services to try and stay afloat.
Right. I think in some institutions, the staffing challenges might be a little harder. And I know, Judy, when we hear from nurses that come to Milford in terms of we don't pay the most, as a community hospital. I think there's definitely higher pay in the city hospitals more, but I think in terms of coming to Milford and being a nurse and having a good staffing ratio, we get good
Right.
feedback about that.
We do. And I think, we're not a union environment, and we encourage our nurses. You want to talk to the nurses. And I can't say that every single time do we always have as many nurses as we want. Sometimes you can't get them, but you're calling and you're trying to staff, and you work with your nurses to make the best decisions. They're the experts. They know what's going on with the patients. And like Ed said, they give exceptional care.
But Judy, I want to be young, thin, and have hair.
Yeah.
I mean, there's things I want.
Yeah.
Would it be nice to have a ratio of 1-to-1?
Yeah.
Of course. Who would say no?
Yes.
But now you turn around and say, okay, now wait a minute. What are you going to do to premiums?
Right.
Because the $5 million that you're adding onto expense, somebody's got to pick up that tab.
Stop talking money.
Yeah.
Money is really, really important here, but what's going to hit consumers, if you just think about our emergency department, and whatever the ratios are, you've got a waiting room full of people. Wouldn't you want to bring as many people in to meet
Yes,
those
you would.
ratios? Okay, what happens when the heart attack shows up?
Well, you know what's going to happen. Jeff is going to take care of him because he'll never turn his back.
And the rule is, which law do you want me to break? Because we have an EMTALA rule that says you have to take care of emergency patients without regards for ability to pay. We do that today, but just in terms of the staffing ratio. So again, how a hospital runs, it runs on the backbones of nursing. It's about flexibility, teamwork, critical thinking. And so things adjust frequently, and frankly, it's amazing to see how it works. And to introduce the government, I don't know how it's going to work.
You want your nurses to tell you what they can handle. You don't want them to say, I can't take another patient because I've reached
Let's
my
face
ratio.
it, we talk about the physicians, and God bless, we're lucky to have the quality. But the nurses are the sergeants of the Army.
Mm-hmm.
They're the ones that make the Army move and accomplish goals.
Mm-hmm.
Again, the only reason I'm talking about money is I don't see anybody talking about this will improve the care. This will make it easier for our mothers, grandmothers to stay in Milford and get quality care. I'm not feeling that at all. I'm looking saying, I'm pretty proud of, in my personal experience, I'm very proud of how your staff took care of my mother. If there was something that I was not happy with, well, you would have gotten a call. But wait a minute, they're getting great service.
Right.
And this just feels like a huge risk that either you're going to cut the services, which I know you won't, because the staff at Milford won't let you. They're not going to cut their quality.
No.
So you're going to cut the number of people. So next time my mother can't get in, or you pay some crazy fine.
We're not trying to scare anyone. We're just worried in terms of the understanding of what this ballot
And
is
how it
about.
will all play out, and what it means really for the profession of nursing. I think it changes the profession. Where nurses have their clinical decision making and can make decisions, and all of a sudden, it's these inflexible mandated ratios that become a priority.
Well,
So
look
that's
what's
the
happened with
concern.
the primary care. I look back, and we could trace all of Milford to one of Cicchetti, Mastriano, 4 physicians that brought you in and threatened that if you didn't behave, they would take you back out. But all of a sudden, the hardest position to fill is primary care. Why? Because government got involved, and they were going to help us with reimbursement. I'm scared to death that they're doing the same thing to nursing.
Right.
I'm begging, saying, show me a benefit. What are we trying to fix? My mom went in the hospital. Tell me, if this was the law, what better service, medical, what would she have gotten that was better after this versus before?
Right. Again, we could, everything, we're not perfect at Milford, but let's just say everything was perfect. This is going to shake the rest of the state up so much that it's going to impact us. So we're really trying to get the word out in various ways to let people know. There is a simple message on the ES side. We've developed our own simple message, really bad for the state, bad for access, really bad, dramatic in terms of the potential of what it means to Milford Regional. And that's our simple message, that this is really puts Milford Regional at risk.
Ed, I think it's profound what you're saying, because I asked a while ago the question, what are we trying to fix? What is the issue? Because I missed it the last 2 times my mother's been in the hospital. And I'm sorry to make it personal, but I was there. I watched how the nurses took care of her and what they did, and I couldn't ask for any better. So again, the fundamental question is...
I think you could say, like a nurse that was in support of years could say, I've worked some busy shifts where I feel like I could use extra help, or I'm busy, or I, had trouble getting my meal break. And we care about those things, and we talk to our nurses, and we always want it to be, you want the best staff, and you want support for them. I don't think these mandated ratios are going to get them what they would want, when you say, of course, none of us wants a day when when you feel like you have more than you can handle or you need more help. We want to, and we always try to talk to them and get them that help and support. But again, I don't think this is going to make it better.
I'd ask the question, if other places are better, how could you hold your staff?
Well, that's what, when I've had nurses say to me, well, at other, it may be good here, but at other hospitals I've had, 8 patients. And I said, if you feel like it's consistently, if it's unsafe, if you can't talk to your manager, then you should look for a different job if you feel like it's not a good place to work. You need to be able to talk about it. We all need to be able to have conversations and make sure we're doing the best for our nurses. They're very important, and they're, like Ed said, they are the backbone, and we need to have those conversations, but I don't think this ballot question is going to solve that problem. I don't think this is going to improve things. I think it will make it worse. So.
And nobody can yet. We've been here for 45 minutes. I haven't heard one benefit. I haven't heard you say, to be balanced, to say
it would be a hardship.
It would improve. We have a problem, and this would fix it.
Yeah, and we've tried to also. We're supporting a no vote. We don't. Any of our written material or the signage says we support a no vote. We don't want to say yes. Nurses say no because we don't want to speak for all our nurses. We know it's a personal decision, and we probably have people on both sides. So that's why we've tried to take kind of that road of, we're telling, our message is decrease access. It's not good for Milford Regional.
Yep. Right. I think on some signs you'll say nurses say yes and nurses say no, and it's confusing. The reason a lot of nurses say no is because organized parts of nurses, because it's only 25% that
86% of the 25%.
Yeah.
Yeah, we're not exactly sure what's in their number, but it was done a long time ago, and it had a disproportionate number of union nurses. But a lot of organized nursing units, professions are coming out against it. That's why nurses say no. Our signs at the hospital don't say specifically. We don't want any confusion that we're representing what our nurses say. We're just saying that this is really bad for Milford Regional and really puts us at risk and is really going to help.
And on that note, I'll agree. I hate to be cold, but Ed, I love what you've done for Milford. The fact that there may be other towns or other areas that this could benefit, may God bless. But I care about our mothers, our fathers, our grandmothers in Milford and what you've built. And if you're going to tell me that gets put at risk to help somebody out in a different community, I'm sorry.
Yeah. We're not sure it does.
Well, no,
yeah,
but-
we're not saying that it does either. Yeah,
No, you're
yeah,
being very
yeah,
open, saying
yeah.
it could.
Yeah.
Good, yeah.
And we want to be very clear. We've had a great run at Milford Regional. It's a great place. We've grown it up. We've got doctors coming from Boston and Worcester. Patients can get a lot more care in Milford. We've got Dana-Farber across the street. We've got Brigham now with 2 linear accelerators. We've got residents and medical students. We've got it's kind of hard to keep things going, but we've got a really great facility, and why? Because of the team that we've had at Milford Regional. It's the entire team. It's the community. It's been their generous support. It's town government in terms of working with them. The nurses are the backbone of the hospital. They've been a big part of that. We just want to get the message out that we think that this is going to be incredibly disruptive to what we have. And we don't want to look back and have any regrets that we didn't get the word out.
And you're being very balanced, very upfront and honest, as you always have been. As we come to the end of this show, I don't see it. And again, I care about Milford. It may be nice for other parts of the state, maybe, but I don't see a benefit. I love the way my mom was treated, the care she got, and someday it'll be me, and I want to make sure it's there when I'm there. If there was a benefit that this would, clearly show, we got a problem, we're losing all our nurses, we're not able to do this, then I might have a different opinion, but right now, I don't see any benefit. But I'll never ask you to vote one way or another. Not my place. I will ask you to become educated. This is one old man who's confused, who likes what we have and only sees risk here, and I don't see a lot of benefit. So I'll beg you, get out and vote, but when you vote, make sure you understand what are the risks. Fundamentally, what's the problem we're trying to fix? And that's really the issue. They're being, as management at the Milford Regional Center, they're being very, very transparent and open. As a resident who cares about his mom and my own self, I don't have to be. I like what we got. I'm proud of what we got, and all I see is risk. And if nothing else, risk to my pocketbook, because eventually somebody's got to pay. And it's always premiums that pay. So hats off to everything you've accomplished, and I only pray that whatever way this comes out, we stay the same. Or get a little better, as Ed says all the time. We want to get a little better. So to our 6 loyal viewers, or as Ed said, maybe up to 10
12 tonight.
or 12,
Yeah.
may God bless. May tomorrow be a better day than today. And let's just hope that we keep improving and taking advantage of our little red hospital that grew into a world-class medical center. Thank you for joining. Thank you for everything
Thank you
you're
all.
doing.
Thank you.
Good night.
Good night.
Not too long since I've been home.